Charlie is 68 years old. Every morning for 11 years, he woke up with a pounding headache, shaking hands, and the feeling that something was very wrong. He wasn't skipping his medication. He wasn't eating badly. He was doing exactly what his doctor told him, taking his blood pressure tablet every single morning at 8 o'clock. He had done it for so long that it was as automatic as brushing his teeth. And still, by 5 in the morning, his body was staging a revolt. His wife would find him at the kitchen table before sunrise, pressing his fingers against his temples, waiting for the worst of it to pass. He chalked it up to getting older. His doctor chalked it up to poorly controlled hypertension and adjusted his dose twice in 3 years. Nobody asked about timing. Here's what happened when they finally did. Charlie moved his tablet from 8 in the morning to 9 in the evening. Same medication, same dose, same diet, same lifestyle. Nothing else changed. Within 2 weeks, the morning headaches were gone. The hand tremor faded. His 5 a.m. blood pressure readings, which he had been logging obsessively on a home monitor for years, dropped by 22 points systolic. His doctor looked at the numbers and said, "I don't know what you're doing differently, but your cardiovascular profile looks better than it has in years." One change, evening instead of morning. Now, before you reach for your pill bottle tonight, there is one specific exception that could make this genuinely dangerous for certain people. I'll cover it in detail midway through this video. If you skip ahead, you will miss the part that matters most for roughly half of you watching this. But first, let's understand why timing matters so dramatically. Because once you see the biology, you'll understand how 11 years of morning dosing left Charlie unprotected at the most dangerous moment of his entire day. Let me introduce you to something cardiologists call the morning storm. Every day, between roughly 4 a.m. and 10 a.m., your body undergoes one of the most dramatic biological shifts it experiences in any 24-hour period. Cortisol surges. Your sympathetic nervous system activates and accelerates. Blood vessels constrict. Platelet activity increases, meaning your blood literally becomes thicker and stickier in these hours. Clotting factors are more active. Arterial walls are under greater mechanical stress, and blood pressure spikes. Not a gentle rise, a surge. For people managing hypertension, this window typically produces a 20 to 30 point jump in systolic pressure within a 2-hour window. If your baseline is already elevated, that surge is starting from a higher floor. The arithmetic becomes dangerous very quickly. Think of it this way. Your cardiovascular system operates like a pressurized pipeline. During the day, the pump runs at a managed level. Then at 4 a.m., an internal biological alarm goes off, flooding the system with activating hormones, stiffening the pipes, thickening the fluid moving through them. For a healthy heart and clean arteries, the system handles it. For someone whose pipeline is already under strain, that daily surge is where the damage accumulates. Research published in the journal Circulation confirmed what cardiologists had suspected for years. The risk of cardiovascular events is 3 times higher between 6 and noon than at any other point in the day. 3 times. Not 20% more. Not double. 3 times. This is not a subtle statistical footnote. This is why the timing of your protection matters so profoundly. Now here is the question that should immediately follow that number. Where is your medication during this storm? If you take your blood pressure pill at 8 in the morning, do the math with me. Most modern antihypertensives, ACE inhibitors, ARBs, calcium channel blockers, have a half-life somewhere between 12 and 24 hours. By 5 a.m. the following morning, that's 20 to 21 hours after your dose, the drug concentration in your bloodstream is at its absolute lowest point of the entire day. You are standing in the eye of the biological storm, and your pharmaceutical protection is nearly gone. You feel fine during the afternoon. Your 2 p.m. reading looks reasonable. Your doctor reviews your chart, sees manageable daytime numbers, and says, "Good, keep doing what you're doing." But neither of you is looking at what is happening at 5 a.m. when the storm arrives and the drug is running out. The gap between when protection is weakest and when danger is highest is not a gap that should exist. The first practical action right now. Find out exactly what time you take your medication. Write it down. Then think about what time your blood pressure tends to be at its worst. For most people watching this, there is a significant gap between those 2 times. That gap is the problem we are solving today. Now let me give you the context that almost no doctor ever explains. because understanding it would change how you think about everything related to your prescription. The reason millions of people take their blood pressure medication in the morning has nothing to do with cardiovascular physiology. It has nothing to do with clinical evidence showing morning dosing produces better outcomes. It is a historical accident. And it traces back to 1955. In 1955, the first antihypertensive drugs entered clinical practice. These were powerful diuretics, chlorothiazide being the first widely prescribed. They worked by aggressively flushing sodium and water from the body through the kidneys, which reduced blood volume and lowered pressure. The problem was obvious within months of widespread use. Patients who took these medications at night were waking up every 45 minutes. Bathroom, back to bed, bathroom again. The disruption was so severe that many patients stopped taking the drug entirely. Physicians moved dosing to the morning hours. Patients could sleep again, and the recommendation became standard. That recommendation was written into medical guidelines in the 1960s, and then copied into the next edition, and the one after that. Here is the part that should make you pause. The medications are now completely different. Lisinopril does not aggressively pull sodium from your kidneys the way chlorothiazide did. Losartan does not. Amlodipine does not. These modern drugs work through entirely different mechanisms, blocking the renin-angiotensin system, or relaxing calcium channels in blood vessel walls. The bathroom at midnight problem simply does not exist for them. But the morning dosing guideline, copied into the next generation of textbooks, absorbed into the training of every physician over the last 70 years, it stayed. Not because it is optimal for your heart, because it is familiar, because it has never been seriously questioned in a standard 10-minute appointment, because inertia, even in medicine, is a powerful force. I've spoken with cardiologists who openly acknowledge this. One put it plainly: we tell patients to take it in the morning because that's what we were taught. Very few of us ever ask who decided that, or why. Your practical step here: identify which family your medication belongs to. ACE inhibitors, the ones that typically end in pril, lisinopril, ramipril, perindopril, enalapril. ARBs, the ones that end in sartan, losartan, valsartan, telmisartan, irbesartan. Calcium channel blockers: amlodipine, felodipine, nifedipine. If your drug belongs to one of these three families, the morning timing was never designed with your cardiovascular peak risk in mind. It was designed around a bathroom problem from a drug that no longer exists in common use. That is a conversation worth having with your doctor. Let's look at what the research actually shows when the timing changes. The HYGIA Trial came out of the University of Vigo in Spain. Published in the European Heart Journal in 2019. It is one of the largest blood pressure timing studies ever conducted. 19,000 patients, 6 years of continuous follow-up. Half took their medication in the morning as usual. Half took an identical medication at the same dose at bedtime. The results were significant enough to generate substantial discussion in cardiology circles. The bedtime group showed a 56% reduction in the risk of death from cardiovascular causes, 49% fewer heart attacks, 42% fewer strokes, 56%. Same drug, same dose, same patients, different clock. Now, some researchers have raised methodological questions about this trial, and the science is still developing. Subsequent studies have shown more modest effects in certain populations. This is worth mentioning honestly. The scientific conversation around chronotherapy and hypertension is ongoing, but the directional finding that timing affects protection is supported across multiple lines of evidence. And the biological mechanism behind it is not in dispute. Let me explain that mechanism because this is the part that will stay with you. Under normal healthy physiology, blood pressure drops naturally during sleep, 10 to 20% below your daytime average. Cardiologists call this the nocturnal dip, and it is not a passive event. It is an active biological process that your cardiovascular system depends on. During the dip, your kidneys rest and recover. Blood vessels in your brain relax and repair micro damage accumulated during the day. Your heart rate slows. The walls of your arteries, which have been under constant mechanical pressure for 16 or more waking hours, finally get a sustained period of reduced load. The entire cardiovascular system uses the night for maintenance and restoration. Think of it like a highway. During the day, the road is under constant traffic. wear accumulating with every vehicle that passes. The nocturnal dip is road maintenance, the window when the traffic slows and repairs can actually happen. If traffic never stops, the road degrades faster than maintenance can keep up with. In people managing hypertension, especially those over 60, this nocturnal dip frequently disappears. The pressure stays elevated through the night, pressing against arterial walls for 7, 8, 9 hours without relief. Night after night, year after year, without ever producing a symptom that would flag it in a routine daytime appointment. Researchers have a clinical term for people who do not experience the dip. They are called non-dippers. And the data on non-dippers is sobering. Higher rates of kidney disease, faster cognitive decline, elevated risk of left ventricular hypertrophy, where the heart muscle thickens and stiffens from years of working against elevated resistance, and significantly elevated stroke risk compared to people who dip normally. An evening dose of medication helps restore that dip. It reduces pressure precisely during the hours when your cardiovascular system needs protection most. It creates a window of genuine rest for your arteries, your kidneys, and the smaller blood vessels supplying your brain. And it ensures that when the morning storm arrives at 5 a.m., your medication is at or near peak concentration, rather than quietly exiting your system. Your action here is specific. Ask your doctor whether you have ever had a 24-hour ambulatory blood pressure measurement. This is a small monitor worn on your arm throughout a full day and night, and it gives a continuous record of your pressure, including during sleep. Without that data, neither you nor your doctor actually knows whether your nocturnal dip exists. You are managing a problem you cannot fully see. You are making treatment decisions based on a partial picture. A 24-hour reading changes that entirely. Now we go practical. 4 specific things you can do tonight, starting this evening, that support lower blood pressure during the hours you sleep. The first one surprises almost everyone. Aged cheese at dinner is a vasoconstrictor. Cheddar, Parmesan, Gouda, blue cheese, aged brie. These foods contain high concentrations of tyramine. Tyramine is an amino acid that triggers the release of norepinephrine, which is your body's primary vasoconstricting chemical. When norepinephrine is released, blood vessels narrow. Blood pressure rises. The effect typically peaks within 1 to 2 hours of eating, meaning a late dinner featuring aged cheese can push your pressure up precisely as you are heading towards sleep. Eat aged cheese in the evening, and you can expect a pressure elevation around 10 or 11 p.m., precisely when your body should be entering its natural dipping window. You are introducing a vasoconstrictor at exactly the wrong moment. Soft cheeses, ricotta, fresh mozzarella, cottage cheese, contain minimal tyramine and present no problem. Enjoy your aged cheeses at lunch. Keep your evenings clean. The second thing, your sleeping position matters more than most people realize. Sleeping on your back significantly increases the risk of obstructive sleep apnea. This is the condition where the soft tissue of the throat partially collapses during sleep, briefly blocking the airway. Each time this happens, the brain registers a threat and triggers a cortisol and adrenaline response. Blood pressure spikes with each event. Some people experience 30 to 50 of these events per hour throughout the night and never fully wake up. They simply feel exhausted in the morning and wonder why their pressure is already elevated before they have had breakfast or a cup of tea. They may have been doing this for years, completely unaware. Side sleeping substantially reduces this risk. Left side sleeping in particular is favorable for cardiovascular function. It reduces mechanical pressure on the aorta and supports more efficient lymphatic drainage. A body pillow placed against your back can help you maintain position through the night without consciously thinking about it. If you or someone you sleep beside snores heavily, stops breathing momentarily, or wakes gasping, that is not just an annoyance. That is a clinical pattern worth investigating. Untreated sleep apnea is one of the most consistent drivers of treatment-resistant hypertension, meaning blood pressure that stays high despite medication. Treating the apnea often brings the numbers down more effectively than increasing the dose. The third, water timing. Drinking significant amounts of fluid within 2 hours of sleep means your kidneys will be processing it at 1 or 2 in the morning. You wake up. Your sleep architecture is disrupted. Fragmented sleep consistently elevates cortisol the following morning, increases systemic inflammation, and raises blood pressure. Front-load your hydration. Aim to drink the majority of your daily water before 6 p.m. A small sip to take your evening medication is completely fine, but large fluid intake in the evening is working against your cardiovascular recovery, undoing part of what the medication is trying to accomplish. Fourth, and I want you to take this one seriously, because it is the most chronically underestimated factor in evening blood pressure elevation. Your nervous system does not distinguish between a news story about a crisis and an actual threat in your environment. Your amygdala, the threat processing center of your brain, generates the same neuroendocrine response to both. Cortisol, elevated heart rate, norepinephrine release, vasoconstriction. The mechanism is identical whether the threat is real or delivered through a screen. A stressful news segment at 9 p.m. can keep your blood pressure elevated past midnight. An argument before bed may not be fully resolved in your nervous system until 2 or 3 in the morning. Emotionally activating content, confrontational television, difficult phone calls, all of these have a measurable physiological tail that extends well beyond the event itself. Create a hard boundary. No news, no conflict-driven content, no emotionally activating material for 2 to 3 hours before sleep. This is not a soft lifestyle suggestion. For anyone managing hypertension, this boundary functions as a direct medical intervention. It protects the window you need for your medication to do its best work. Now I need to stop you completely, because here is the part that applies to roughly half of you watching. And it is the reason I told you at the beginning not to reach for your pill bottle without hearing this first. Not all blood pressure medications benefit from bedtime dosing. And for 2 specific drug categories, taking them at night can create problems that significantly offset everything else I have described. The first category, diuretics, hydrochlorothiazide, furosemide, chlorthalidone, spironolactone. These are the descendants of that original 1955 medication. They still work by increasing kidney filtration and urine output. At bedtime, they still cause exactly the same problem they caused 70 years ago. This is not ancient history. This is a real and current issue. You will not sleep through the night. Fragmented sleep from medication-driven bathroom trips raises cortisol, increases inflammation, disrupts glucose metabolism, and elevates morning blood pressure. The drug is doing one job while the sleep disruption undermines your cardiovascular health from an entirely different direction. You end up fighting yourself. If you take a diuretic, the recommended window is 4 to 5 p.m. Late enough in the afternoon to provide some protection as you move toward your early morning risk window, but early enough that the diuretic activity is largely complete before you go to bed. 4 to 5 p.m. is a practical and well-supported compromise, and it is worth discussing directly with whoever prescribed it. The second category requiring caution, beta blockers, metoprolol, atenolol, bisoprolol, carvedilol. These medications reduce blood pressure partly by slowing the heart rate. During sleep, heart rate already decreases naturally. In certain patients, bedtime beta blocker dosing produces bradycardia, an excessively slow resting heart rate, sometimes dropping to 45 or even 40 beats per minute. For some individuals, this is tolerable. For others, depending on age, baseline heart rate, kidney function, and other concurrent medications, it is not appropriate without monitoring. Some patients also report more vivid or disturbing dreams with nighttime beta blocker dosing, which can itself disrupt sleep quality and raise morning cortisol. Do not change the timing of a beta blocker without discussing it first with the physician managing your care. This is a firm line. This is not a gray area. To state the protocol clearly, ACE inhibitors, ARBs, calcium channel blockers, strong candidates for evening or bedtime dosing. Discuss the HYGIA trial with your doctor by name. Ask specifically about your nocturnal dipping pattern and whether a 24-hour ambulatory reading has ever been done. Diuretics. Move to 4 to 5 p.m. Not morning, not bedtime. Beta blockers. No change in timing without direct medical supervision. This is the exception I promised you at the start. This is the reason I will always tell you that information from a video, however grounded in evidence, is the beginning of a conversation with your doctor, not a replacement for one. Your doctor knows your full picture. Use this information to have a better, more specific, more productive conversation, not to make a unilateral change. Charlie's story ends well. After 11 years of morning headaches, trembling hands, and sitting alone in a dark kitchen before sunrise, waiting for the worst to pass. Charlie asked his cardiologist one direct question. He said, "Is there any clinical evidence for me specifically taking this drug in the morning? Or is it just the default recommendation?" His doctor paused, searched the literature, found the HYGIA Trial, reviewed Charlie's medication class, an ACE inhibitor, no diuretic, no beta blocker, and said, "Let's run a 2-week trial with evening dosing and track your home monitor readings." 2 weeks later, Charlie's 5 a.m. readings had dropped by more than 20 points. Morning headaches gone, hands steady. He was sleeping through to 6, sometimes 6:30. For the first time in 11 years, he was waking up feeling like himself. His wife told him he looked 10 years younger at the breakfast table. He wasn't wincing. He wasn't gripping the edge of the counter. He was just sitting there, drinking his coffee, watching the garden. 11 years. One question. Your body has a rhythm. Your blood pressure has a rhythm. The morning storm arrives at the same time every day, without exception. The question is whether your medication is present and active when it arrives, or whether it spent the night quietly clearing from your system while you slept, leaving you exposed precisely when the risk is highest. One conversation with your doctor can answer that. Mention the HYGIA Trial by name. Ask about your 24-hour ambulatory readings. Ask whether your specific medication class is a candidate for evening dosing. That conversation might be one of the most important ones you have this year. Not because the answer is guaranteed to be yes, but because the question itself has likely never been asked. I want to ask you something directly. What time do you currently take your blood pressure medication? Write it in the comments below. And tell me, has anyone ever explained to you why that specific time was chosen? In my experience, most people have been doing it for years, sometimes decades, and have never once been offered a reason. No explanation, no evidence. Just take it in the morning. I am genuinely curious how many of you are going to look at your pill bottle tonight with completely different eyes. If this was useful, pass it on to someone managing hypertension. The timing question almost never comes up in a standard 10-minute appointment. There simply is not room for it. But it can change everything. And if you want to go deeper on why what happens to your blood pressure during sleep affects your kidneys, your memory, and your cognitive health over the long term, I covered all of that in detail in another video. The link is in the description. Take care of your heart. I'll see you in the next one.